Production funding for Behind the Headlines is made possible in part by the WKNO Production Fund, the WKNO Endowment Fund, and by viewers like you. Thank you.
New approaches to healing children tonight on Behind the Headlines. I'm Eric Barnes, President and Executive Editor of the Daily Memphian. Thanks for joining us. I'm joined tonight by Mary Armour, President and CEO of Le Bonheur Children's Hospital. Thanks for being here.
Thanks for having us.
John McCullers is Pediatrician-in-Chief for Le Bonheur. Thank you for being here.
Eric, thanks for having us here today.
Along with Bill Dries, reporter with the Daily Memphian. So I wanted to have you all on after I was at a lunch meeting and you all talked about a family resilience program that was fascinating and interesting. And we'll start there and then kind of go from there into a variety of community engagement and community outreach sort of programs you have, and all things Le Bonheur, which is obviously one of the great, institutions in Memphis, healing children and so on. But talk about, I guess I'll start with you, Mary. What is this family resilience program, and the what's so new about it in terms of how you're approaching healthcare for children?
Well, the Family Resilience Program is really created by Dr. McCullers and some of his colleagues in his department. But the gist of it is really to find ways that we're identifying kids who might be in families who are really struggling, and to identify them early and to identify the stress that they're going under. And so the hope is that we can intervene quicker and more effectively for them.
The formal program, was it last summer that it started, Dr. McCullers?
Yeah, we started last January. We put it together and we started seeing kids and serving families starting in May. Okay. And this had been the result of about a 2-year build-up where we had done a lot of research into these issues around adverse childhood events and social determinants of health, and began to realize that this was having a much broader and longer lasting and significant impact on kids than we had really thought about before. And that kind of spurred the necessity to get into this space and to start working with kids and families this way.
So give some examples for those adverse impacts. I mean, some of the things you talked about were, I won't call them simple, but they were, or basic, because they're hugely important, but things like food. Are they getting enough food? Are they living in a secure environment where they know where they're going to sleep that night? Talk about some of those adverse conditions that you're looking into as they come in with maybe the flu, or they come in with a common cold, but there's all these sort of spiraling issues outside of that.
Yeah, there's two really basic things that we're looking into with this. The first is something called adverse childhood events or childhood trauma, where kids are exposed to things in early childhood in the household, things that may be domestic violence or drug use or alcohol abuse. And we've learned through research in recent years that, everybody knows it's not a good environment to be in, but we've learned that there are permanent damage that can be done to kids' brains when they're exposed to that at an early age. And that may manifest itself later in issues with education, with being able to hold down a job, or with medical problems like cancer and diabetes and so on. So the ability to screen and try to intervene early from a health perspective really became a necessity to us. The second issue is the one you allude to, is that these things called social determinants of health. Do you have working heat in your house? Do you have transportation to bring your child to the hospital? Are you more worried about food and putting food on the table than you are about filling a prescription? This really interferes with our ability as a hospital and as physicians to provide appropriate care. If I have a kid with asthma and I want to treat them for their asthma, but there are these other things that are more important, food and security, than treating the asthma, well, what's going to happen. They're not going to get treated, and it's going to become a worse problem.
Bill.
Doctor, are children and their parents somewhat hesitant to go beyond what the immediate concerns are, because there are public relations campaigns about tell your doctor what's really wrong with you as opposed to what you think the doctor wants to hear. And the reason I ask it is because I would imagine at a children's hospital, doctors have to know how to communicate with patients anyway, in a level that you might not see with adults.
Yeah, it's been really interesting seeing how this has kind of rolled out over the past year with that exact issue, which is something we were worried about. So first of all, we had very intensive training for all of our physicians, all of our nurses, our staff, our community health workers that are working with these families, so that they understand these issues and can communicate and educate the families about these issues. And the second thing we found that if we start with some of these, simpler things like, are you having issues with running out of money for food at the end of the month, or are you having problems with where you're going to sleep tonight, that there's a bit of a bonding that forms there because we're concerned about their well-being and something outside of the medical realm, which isn't typically part of what you do in the physician visit, at least how we were trained. And as you start to kind of get into those questions, now it becomes much easier to start to ask the other questions of those adverse childhood experiences around domestic violence and child abuse and those sort of things.
Mm-hmm. How much work was it to kind of knit together the network that goes beyond those inquiries to actual help outside of the hospital?
Well, I think that the issue that Dr. McCullers raises is very real for so many of the children that we take care of in Memphis. And so while there are social agencies and groups out there working for it, the ability to connect those moms and children with those agencies is what's always been hard. And so one of the things that the Family Resilience Initiative does is it makes that direct, warm connection to the person or the group that can really help them, whether that's housing or food or transportation. And I would add to what John said, and that is that as the pediatricians have sort of really adopted this model, it's now part of their regular conversation with families over and over and over again. And so it's not sort of the routine check off the box, are you a victim of violence in your home? But it's really more of a very soft touch about, tell me a little bit about how things were going at home for you, and what do you think's interfering with things? And we've seen that with our asthma program, and now we're seeing it with this particular initiative, which is really a powerful one to address the incredible determinants of health that really get in the way of children being safe and healthy and growing up strong.
And as I remember from when I had the advantage of hearing y'all talk about this before, there were, again, I say simple, but they're complicated and they're expensive and so on, but giving people, not just sending people home knowing that they might not have enough money for food, but giving them a ride, giving them a Lyft or Uber or some kind of ride out to the food bank. Is that right? That's that outreach, and not just, again, taking down the data and tracking it, but trying to make an immediate impact.
Yeah, it really is that warm handoff of like not making them stand in line for a food bank, but really trying to connect them with a person who can be their advocate in that other agency. Right. And I think that's been one of the great successes of this, is that it really is connecting not only the providers but the families with other people in the city that can help. And there are lots of other agencies that want to help, but getting parents there is a problem. Getting them to accept help sometimes is a problem. And so the Family Resilience Initiative is really the vehicle that helps move them from that dependency, I don't know what to do to help myself, to how can we really get stronger as a family unit and really get the needs of the child met.
Yeah, what we found as we looked around the country at other programs that were starting to do this, that there was an increasing awareness of what a big issue this was in the lives of children. Mm-hmm. And there were a number of programs that were starting to screen, right? So let's screen, let's see if there are food insecurity or there are these experiences in the household. But the problem was nobody knew what to do once that screen was positive. You would find this out, but then physicians were trained with dealing with the medical issues. We're not trained in the social services realm and how do you fix some of these issues. So we had to come up with a comprehensive program that, again, not only screened but assessed and then did something about it, provided something and then followed up and made sure that connection was made and that the problem had been fixed, so that we kind of closed the loop on it. And that was what was different about this program.
And the ability to send community health workers out to homes if in fact there was a greater need that was identified, so we could just check up on them again, make sure we're more connected than we were before.
You talked, you mentioned asthma, and some of that was not just treating the asthma with medication, but making sure the home might have mold in it, the mattress. There was all these kinds of things that are sort of common sense when you say them, but aren't what you typically think of as a hospital doing. I think if the hospital is giving someone, an inhaler and some pills and, and recommending they do X and Y, but none of that. I think it was Dr. McCullers or one of you who had said
Yep.
that doesn't really help if they're in a home that has mold
Exactly,
and so on.
exactly. So I'll launch into the CHAMP program, which was a CMS innovation grant we did in 2012, and it really was looking at children who had been in our emergency room 3 or more times in a year, or who had been admitted to our intensive care unit. Those were what we called high-risk asthma victims. And Memphis is a notorious place for asthma for both children and adults for lots of reasons. But the CHAMP program was very successful. In fact, it's being touted right now by Bill Lee, our new governor, as being one of the models that sort of shows you can improve health and well-being and still save the state money in doing that. So we actually identified those children, enrolled them in a program where they were both educated, their parents were educated. We followed their prescribing patterns. We followed up with them in their homes on a regular basis. We sent people out to their schools to make sure the school nurses knew how to do inhalers. And all of that has resulted in a massive improvement in children's asthma care. 54% reduction in hospital admissions, 94% compliance rate with their drugs therapy. And I'll just tell you one quick story. We had a 6-year-old that was in his kindergarten class, and he knew he was having an asthma attack because he had been educated as a child through the CHAMPS program. And he went to the school nurse's office and said, I think I'm having an asthma attack. And of course, all their inhalers are behind locked doors and everything. And the provider that was in the school office didn't know how to work the inhaler. And he said, here, give it to me. I know how to do it. And did it and took care of himself. And that's exactly what we want, is to see kids get that kind of independent self-care. We think that's a good thing for them in the long run.
Yep. Bill.
So is this part of an overall evolution that has changed how we look at hospitals in general? I mean, obviously there's a handoff to some agencies, but as both of you have said, this is not just looking at a clipboard and going through checking boxes off on this.
It's not that.
So we really want this to be and the next phase of how we take care of children, because it just makes so much sense to be out there, thinking about, you think about a hospital, people come into the hospital, you treat them, they leave, and they go back to their doctor or wherever they're going. And that clearly isn't sufficient when you have all these barriers to care and all these societal issues that create this situation where you with chronic disease, and you can't manage chronic disease. And so we have to evolve to this view where we're outside the walls, and the hospital now is more of a platform to project healthcare into a community and to make people well, as opposed to treating their disease that's developed because there's nothing out there to stop them from getting sick. And so these programs we're talking about today are a start of that, but it has to be part of a larger evolution and overall conversation about how healthcare is delivered. Now, the barrier to that is the way physicians and hospitals and the healthcare systems are paid to deliver care. That's not it. They're paid episodically when a patient comes into the hospital. That's taken care of, and those payments are why we have the ability to care for children. And so far, nobody wants to pay us to be out in the community and preventing that from happening. And that's the evolution we're trying to go through, where not just show that we can deliver and do the research to say we can really make a difference and make this better, at which point we hope then that the insurance companies and the healthcare systems will come along and say, okay, this makes sense both fiscally and in terms of the well-being of our citizens and so on.
Mm-hmm. But insurance companies are the ones who have these wellness programs that you go through at some companies if you have health insurance. So why is there the hesitancy to look at this as a part of wellness?
Well, remember that most of the children that we see in Memphis are really in a health disparities situation. I mean, they really don't have access to the same kind of resources that commercially insured adults do, nor do they have people looking out for them. That's why we believe that the Children's Hospital really is ground zero for making certain that we reach out and take on more of children in the community and in schools, and not just when they're sick and in the hospital. Memphis's children are significantly disadvantaged, more so than in many parts of the country. And so we've evolved a lot of programs to try and address that problem, because we really do kind of want to see ourselves get put out of business. We'd like to see children be well and grow up healthy and not really need us unless there was, something that was a fixable, easy problem. Mm-hmm. The social determinants of health aren't easy, fixable problems. But for us, And I think it's sort of philosophical for children's hospitals is that if you start with a child and you make their life and their health and their well-being your priority, you can't help but end up with stronger, healthier adults who can really contribute to society. And what John talks about is that we know from the ACEs research that kids that are exposed to 4 or 5 or more ACEs in their childhood are at significant risk for problems.
ACEs, define that for
adverse childhood events.
Okay. Which is interesting because you talk about that. We've done a number of shows over the years, but particularly lately about the Juvenile Justice Center. I won't have you get into that, but I mean, people talk about the same things. We had Dorsey Hobson, the former superintendent, talking about the exact same things. How does the school educate someone to reading and writing and so on when they haven't eaten, when they're not in a secure place where they're sleeping, when so many of the kids in the Shelby County school system are living in poverty. And so it's an interesting way in which all these kinds of issues intersect, which part of why was so fascinating to me. With 10 minutes, you mentioned this, 10 minutes left, you mentioned the business side of this. I mean, Le Bonheur is a business in the sense, I mean, it's a nonprofit business, but it's a business in the sense that you're taking fees and you're paying people. It's I don't know, what is your annual budget? It's hundreds of millions of dollars? I can't imagine.
335 million,
so
something like that.
You are balancing that. You're trying to serve everyone, I assume, and kids in need, whether or not they have insurance. How do you pay for these kids? Like you mentioned, a child who comes through the emergency room. Emergency visit is incredibly expensive.
Yes.
And often that family is not able to pay the full cost, I assume, for many people living in poverty.
Right.
How do you pay for that?
Exactly. Well, we are like a lot of children's hospitals, and that is that we are a not-for-profit, so whatever we do earn in a year, should that be positive, that gets churned right back into the healthcare system. But we, like many children's hospitals, rely heavily on grant makers like Dr. McCullers finding federal money, foundation money that will help support initiatives. The CHAMP program was an example of that, started out as a federal grant. And then, of course, we rely on philanthropy. So we do have an endowment that we are continuing to raise funds for that we hope will provide money for Care for All Children. And we have funded the CHAMP program, for example, through that account, because when the grant ended with the federal government, everybody said, oh, that's great, you guys did a wonderful job. You're the only program that we saw in this series that really actually has evidence-based proof that you were successful. And of course, TennCare loves it and saving them money. Kids aren't going to the hospital, they're getting their drugs filled, but nobody's paying us to do that. So the community health workers aren't really getting funding for us sending them out to the homes. So we have to rely on other people many times to help us keep it going. But we said, and we will probably say the same thing with the Family Resilience Initiative, once the funds dry up, if there's evidence that it works, there's no way that as a children's hospital you can walk away from that. So you just make choices in your budget about what you're going to support, and we couldn't walk away from the kids with asthma, and we won't be able to walk away from these kids with the ACEs initiative. We'll find a way, we'll keep talking to people till we get the answers and the dollars we need.
Doctor, talking to you about this business side of healthcare, which has been, changing so much over the last decade. The Affordable Care Act, Obamacare had huge changes, not just in terms of how people, most people listening, if they're not in the profession, there were huge changes to how they maybe got insurance. But for you, there were huge changes in what was expected of you, I think, in some ways. The inner workings of healthcare changed dramatically over the last 10 years. Some of that stuff has been undone. But what are the biggest impacts over the last 10 years from, and I don't mean this in a political way, I'm not asking that, but from the Affordable Care Act as a person delivering care? What have you seen that's worked and what have you seen that hasn't?
So the biggest issue we have at Le Bonheur is that the great majority of our children own public insurance, so typically Medicaid or the CHIP program. And truthfully, in Tennessee, almost every child is eligible to be covered under one of those. It's a very different situation with adults where we did not have Medicaid expansion within Tennessee, and so there were a large number of working adults who are in poverty but don't qualify to have any sort of public insurance and then don't have insurance through their employer. So that's a large pool of uninsured. We don't have many of those within the children's health sphere. What we do have, though, is that our public assistance programs, or public insurance, don't pay very well. They don't cover the cost that of, for us to care appropriately for children. And so this is, again, on the business side, this is why it's very important for us to have these sort of community-based programs, because if I'm losing money seeing a child in the emergency department because they have an asthma exacerbation, and I can prevent that asthma exacerbation, even though it costs me money to prevent it, the net gain of not losing as much money in the ED is going to be positive for the system. Right, so we're able to work on population health initiatives, trying to keep our kids in the community healthier so they don't need us, because we're going to lose money if we're taking care of them in that way anyway.
But even if you have a community health worker who you send out to a home to a child who has CHIP or Medicaid, or you're not paid for that. That's not covered by CHIP or TennCare?
That's correct.
Okay. Bill.
What was the response from the philanthropic community, from the organizations that award grants when you first went to them and talked about this?
Yeah, I'll say that Memphis is an incredibly generous city from that perspective, and the foundations, many foundations across the city and the region have been extremely supportive of us, and I think rightfully so. When you can come and speak to these sort of issues, particularly around children, and have a vision for how you're going to impact that and make change that is positive, I think it's a message that resonates. So this particular Family Resilience Initiative program started with a grant from the state that Senators Mark Norris and Mark White were able to get the state to fund this because they saw the importance of it. They knew how important Le Bonheur was in the lives of these children. That grant ended after a year, but the philanthropic community has stepped in for the second year now of the program. And we're hoping to continue to be able to rely on philanthropy going forward. But again, in the long term, to be sustainable, this has to become more a part of the fabric of how we do business. And we have to be, it has to be reimbursed within the insurance companies and the health system if it's going to work long term.
It might seem simple, but it seems like there is a basic shift in this in the places that people go, because you're not just giving them a slip of paper and saying go to this place. Am I correct?
That's correct. So when we connect now to social services, we have a validated list of social services. We follow up with the families and with the social services organizations to make sure they do what they said they were going to do, and to make sure our families have followed up and gotten what they really needed out of that. And so, there's a lot of people that want to do good in this space, and some of them are better at it than others. And so we have to make sure we're really utilizing high quality services. And so we have that kind of role of monitoring how well they're doing. So again, it's this wonderful outpouring of support from the community, but the ability to access it, it's such a difficult thing, and we can make that a lot easier through a number of different ways.
And I'll just add quickly, one of the things that has evolved as a result of our outreach in the community is the development of this medical legal partnership, which is actually a triple effort funded by Le Bonheur, the University of Memphis Law School, and the University of Tennessee College of Medicine. And it really is taking those families who have legal concerns, can't get disability payments for their child with serious chronic illnesses, have housing concerns that the landlords won't deal with. They actually take those cases on completely pro bono. The Memphis Legal Association sends a volunteer attorney for us. The law school sends 2 attorneys. We pay for an attorney. And so we actually help those families once they get identified in the Family Resilience Initiative or the CHAMPS program or wherever, and take them to the next step. If we can get them legal support, that's one way to ensure their comfort level for a long time.
So we're in the legal business too at Le Bonheur.
Yeah, we have lawyers too.
With just a couple minutes left, you are retiring this year after 12 years at Le Bonheur. Your high points over the last 12 years and low points over the last 12 years.
Well, the high points have obviously been the great success Le Bonheur has had, being recognized nationally as one of the country's great children's hospitals. Very proud of that, and very proud of the people, the physicians, the nurses, the technicians. Everybody that's there has the same culture that we're just talking about today. It's really all about the kids for all of us.
And low points, or points of frustration that you feel like, I mean, you must have had days where you just felt like, boy, this was hard. kids who are we've been talking about kids in terrible circumstances, and it must get to you sometimes on a very personal level.
Yeah, I think sometimes it is hard, and it's particularly hard for some of our providers who see children who haven't enjoyed the love of family and the support, who've been either abused or neglected, and children who just simply are struggling because their parents don't have the money to take care of them or the social structure to do it. Those are very tough days for them.
Do you feel though that you know, again, you've been in healthcare, you were a nurse, and then moved into the administration side. In your career, all in all, I mean, there's been poverty for quite some time, and there's been these kinds of troubles we're talking about. Do you feel the trajectory is better or is kind of the same?
I'm really proud of what pediatric medicine has done over the last several years. I mean, we've continued to jump the curve in terms of how we treat diseases and keep kids out of the hospital. And now I think pediatrics is again leading the way in this whole concept of health disparities and social determinants of health. And I think our adult colleagues will have to follow sooner rather than later.
Yeah, and last thing, and we could talk a whole show about this, but I'm always curious about the partnerships between all the various institutions. And we talked about y'all being a business, but there's a lot of partnering between you and Baptist, or you and the College of the Health Medical School, UT.
Yes.
Talk about that role of partnerships quickly. Is that increased over the last 12 years, or is that my imagination?
No, it absolutely has. And I think John and I have worked really hard at continuing to build those strong partnerships. Certainly his relationship with St. Jude is there, University of Tennessee Health Science Center, University of Memphis, and all of the foundations and people that support us. We work really hard to make certain we're good partners.
Okay. Well, thank you, Dr. McCullers, and thank you, Bill. Thank you for joining us. Join us again next week.
Thank you.